Susan. Yeah, she's correct. I did do the collaborative program in aging during my PhD, actually, which was a number of years ago. Actually, I finished my PhD 10 years ago. It was 2004, actually, now that I think about it. So now I'm on faculty in the Department of Occupational Science and Occupational Therapy and the Graduate Department of Rehab Sciences. And I have got tenure this past year, and I'm on my first sabbatical right now. So I'm in here sharing some work that I've been doing over the past, we're going to have feedback because I can hear myself. There. Sorry. That's okay. So maybe since it's a small group, you can introduce yourselves a little bit so I have an idea of who it is that I'm speaking with. And we'll start over here with you guys.
Paul Hundred, and I'm at an adult day program for stroke survivors at Central Neighborhood House.
Oh, great.
And Anthony is a story round activation student in placement with us.
Okay, great. Welcome.
My name is Grace. I'm a senior service worker at University Settlement, which is a community agency.
Okay.
My name is Gail, and I'm a retired geriatric nurse, and I'm here for both personal and professional.
Yeah, it happens, doesn't it? Yeah.
I'm Ronnie. I'm actually some staff, but I'm former U of T staff and a spouse of retired U of T staff.
Mm-hmm.
And my mother passed away next week 2 years ago of vascular dementia and mini strokes, and
So you've been here and done that. Yes. Yeah.
My name is Franciele, and I'm an undergraduate student of gerontology in Brazilian, and I'm coming to Toronto to study a part of my scientific initiation in Toronto.
Great, welcome.
Thank you.
And thanks again for coming today. I know it's cold out. It's been a very, very cold January. So hopefully as February comes, it'll warm up a little bit. All right, so when Susan asked me to come and give this talk, she asked me specifically to present the results of a large randomized control trial of a stroke family caregiver support program that we were just finishing testing. And I said to her, well, you know, I'd really rather come and tell the whole story because that's really just a piece of the puzzle. And what I thought I would do is give you the story, which provides you with more information on the background and how this whole intervention came about, that we then are in the process of analyzing the data and seeing whether or not the intervention had any impact. And I apologize for, I always have a set of slides and then I keep modifying every time I give a new talk. So it does say Northeastern Ontario Stroke Symposium from 2012, and this really is not that talk. It's my mistake for not updating my footer, so I apologize for that. Some of the slides are the same, but most of them are different. Anyway, so just to give you a little bit of an outline, I'll just provide you with a little bit of background information, and then I do all of my research from a timing perspective. So I'm going to introduce you to this whole idea and why I do the work that I do, the way I do it. I'm going to introduce you to the Timing It Right framework, and then walk you through how you can start with a framework like that that addresses this issue of timing and develop and then test an intervention based on those ideas. And if you have questions as I go along, just let me know. So, and in this audience, this is not much that I shouldn't have to say a lot of this because it's pretty clear to most of us in this room, but it's important to reiterate that family caregivers or family members involved in the care of individuals with any type of disability, they play a valuable role in supporting their recovery, rehabilitation, and reintegration into community living. So they're involved right from the get-go, and they're involved over a long period of time. Hollander and colleagues have done an excellent job estimating the value of the unpaid labor associated with providing care. And they've been able to estimate that this value is over $25 billion per year. So if something happened to family caregivers and they were no longer able to provide care, this would significantly impact the sustainability of our healthcare system. And then it's also important to recognize that it's still, in 2014, not standard clinical practice to prepare and support family members in this caregiving role. So many of them struggle, and I like to give the comparison that I'm involved in the occupational therapy program. Our students spend 2 years with us to get a master's degree. They spend about 1,000 hours in the classroom learning all the material. They spend about 1,000 hours practicing clinically before they can even, take the exam to become an occupational therapist. Now, if somebody is providing care to somebody who's had a stroke, that person may have had no experience with caregiving in the past. The person has had a stroke. They might be going home after a week, after 3 weeks, after 4 weeks, if they're lucky, after 6 weeks, and this family member who's going to be involved in providing care really has very little time to learn anything about what's going to happen and the reality of the home situation. So it's not surprising across illness populations, many family caregivers have, a hard time. Some of them have poor mental health outcomes. Some of them have to give up a lot of their own valued activities and interests. Some of them, it even affects their health physically. So there are negative consequences, or there can be negative consequences to providing care. The good news is that, more recent best practice guidelines, and I use the Canadian Stroke Best Practice Guidelines as an example, has begun to recognize the important role that families play. So they now have a few recommendations that suggest that healthcare system should be providing more support to families. And then here is this cases specifically through transitions. So they're starting to recognize that the support they need isn't just this standard support, but the support is changing as patients and families transition across care environments. But when you look at the caregiver intervention literature that's been done to date, research that's been done to date, caregivers' needs for support through transitions has not really been addressed. So my research, again, takes this perspective of timing. So I just want to walk you through it a little bit. So when I've spoken to family caregivers in the context of research and in context, interacting with them personally, I hear a lot of things, and I'm going to give you a couple specific examples. Now, these are quotes from two different caregivers, but they're talking about the same educational resource. One of them received this educational resource during the acute care hospital stay and found the information to be too much. Another caregiver received that resource for the first time when they were back in the community, and they said it was excellent. So how can one resource be perceived so differently by different people? Because it's the timing. When we talk to stroke survivors, they say that there's something happens as soon as they leave the hospital, the door closes behind them, and it's almost like time stands still. So their support needs continue, but they have really no idea and no place to go to have their support needs met. When I speak with healthcare professionals, they talk about this idea of having a hard time knowing when patients and caregivers are ready to receive information. So they feel that this is a bit of a barrier to them interacting with patients and family and providing more education because they don't want to overwhelm them. So they struggle with this idea of who is ready, when, for what. And when we look at the stroke care system, we are lucky to be in the province of Ontario because we probably have the best stroke care in Canada, in North America. I'm going to Sweden next week to speak with them, and they're starting to incorporate some of the things we're doing in Ontario. So we're in a good place for stroke. And one of the best things about it is they talk about wanting to improve the continuity of care across care environments. And again, for me, this translates directly into benefits for the patients and the family members, because those are the things I would say they struggle with most. So again, the timing is the central link here. When things are happening, so now whenever, people talk about doing research with a gender lens or with an aging lens, I do everything from a timing lens. If somebody tells me something about their research, my first question is, well, when is that in the illness trajectory, and why is it happening then? So I'm not the first person to think about timing, so it's important to recognize work that's been done before me. And Prochaska's Readiness for Change model is probably the foundational model for patient and population health education. So the premise of his work is that you would give a smoking cessation program to somebody who's ready to quit smoking. That program would be very different from somebody who is not yet ready to quit smoking, right? So you really have to target a person's intervention to where they are, how ready they are to change that behavior. Now, Corbin and Strauss has also considered timing. They looked at the different phases that a person will go through after they've had a critical health event. There's the acute care phase, the comeback phase where functional abilities are starting to return, and then a stabilization phase where things aren't changing very much. Now, Nolan and his colleagues are specifically looking at the caregivers' perspectives and how things are changing over time for them. And he's really identified sort of two key phases that are related to stroke, which are this idea of taking it on, or when caregivers decide to become a caregiver, and the other one is working through it, where caregivers are learning to and then providing care. So I felt when I was doing my postdoc, actually is when I started to do this work on intervention development. And what I found was missing was that nobody had taken any of these phase-based or timing sort of approaches and applied it to intervention development and testing, specifically in the area of caregiver support. But the other thing that was missing is that we didn't have a lot of specificity about how support needs were changing across different care environments or across time. So that led, during my postdoc, actually, to the development of what we call the Timing It Right framework. And I developed this with Monique Gignac, who at the time was my postdoc mentor, and I believe is also affiliated with the Aging program. So the idea of this framework is that it's a comprehensive 5-phased approach to support families from the hospital to the home. So it emphasizes the timing of support needs and how they're changing across the care continuum. And the central premise is that if we can address phase-specific needs, we can enhance caregivers' preparedness, ease transitions across care environments, and minimize negative outcomes from occurring. So I'm often asked by some of my healthcare professional colleagues, especially during inpatient rehab, for a measure of caregiver burden that they can give to a caregiver so they know when it's time to intervene. And my standard response is, why are you waiting for them to be burdened before you start to intervene? Is there something you could do, in advance, something a little bit more proactive that can even minimize negative outcomes from occurring in the first place? So that's the premise of this framework. So we published the framework in Patient Education and Counseling, and then a qualitative study that we did using the framework in disability and rehabilitation last year. So just to briefly introduce you to the phases, there are 5 of them. The first 2 occur in the acute care phase. So the first one is the event diagnosis phase. So the idea here is that at this point in time, families' biggest concerns are, is my family member going to survive? What are the tests that you're doing? What do the test results mean? How do I interpret all this information that's coming towards me? Once the patient has stabilized and we know they're going to survive, then the family sort of takes a breath and says, okay, what do I need to know now? What are the next steps? What is a stroke, and how do we start to deal with this? The next phase we call the preparation phase, and this is when families are preparing to take the person who's had a stroke back to the community, either from inpatient acute care or inpatient rehabilitation. So how do they help to, prepare their home? What do they need to learn about rehabilitation? What do they need to learn about supporting this person once they're back in the home environment? And how can they best prepare? The last 2 phases occur in the home environment. The first one we call the implementation phase, or also referred to as the figuring it out phase. So this is when the stroke survivor and their family are in the home for the first time. They're really saying, okay, there is carpets on the floor. There were no carpets in the hospital. How am I going to navigate this toilet compared to the toilet with the bars that I had? So this is basically figuring out how to live in the home environment with any disabilities that the stroke may have caused or resulted in. And then after they figure it out, they move into what we call the adaptation phase. And here's where the priorities become more about, okay, I figured out how to live in the home, but I want to go back to work. Or I want to go back to some social activities that I used to do before the stroke. I want to get back to driving. So it's this idea of getting back to life. And the idea is that across all of these phases, stroke families have different needs for support. So we should be trying to address them and recognize them. Provides a little bit more structure, I think, to the healthcare system in supporting families. When I talk about support, I like to make sure I place it in the context of social support. And there's been a lot of great work done in this area, and Cohen's frameworks, sort of resonates best with me. So when I think of what families need, they need emotional support, they need someone to talk to, they need information. I think that's kind of foundational, especially if this is something that's very new to them. They need tangible, hands-on assistance. Maybe having somebody help you organize services or find services that would be appropriate for you. And then they'll also need training in specific caregiving activities. Maybe they've never done a transfer before. We had a student project recently where we asked stroke families, how do you transition in and out of the car? And I was working with an occupational therapist, and we were appalled at what the families were doing because it wasn't safe for anybody. And we were wondering who taught you how to do these transitions. So that was a missing gap because nobody taught them how to properly transition somebody who's had a stroke in and out of a car. So anyway, so training is a very important piece. And the other thing that we miss often is this idea of appraisal. And that's giving people feedback about the activities they're doing and letting them know what they're doing right, or maybe what they need to fine-tune or do a bit differently. And I think when a family member knows they're doing something right, it's like they can say, okay, all right, I got this right. I don't have to worry about it anymore. I can move on to something else. So anyway, so I like to place, when I talk about giving families support, I'm talking about all of these different elements, not just education, not just emotional support, all the different domains. The good news was that when the 2008 Stroke Best Practice Guidelines came out in Canada, they had bought into our idea of changing needs for supports and how this timing issue. And so they've actually referenced our work to say that when you're providing stroke families with education and support, it should be specific to their phase of, specific and appropriate to their phase of recovery. All right, so we put a lot of work into developing this framework. Actually, it was interesting because when we did the literature review that informed the framework, very few studies actually situated their results in the time post-stroke. So we would see a study where 100, or not 100, so we'll say 50 caregivers or 100 caregivers were interviewed or were surveyed, but they were surveyed at many different times post-stroke. So the conclusions you're making, you can't really make any conclusions about when the needs or the experiences were happening because it was a hodgepodge, right? So when we developed the framework, we based it on the literature we could base it on, and then our existing knowledge of stroke care. So we did need to go back and do a little bit more work, which you'll see in a minute. But anyway, so the idea here was, so now we've got this framework, what can we do with it? Can we operationalize it? Can we create an intervention that we can use to see whether or not taking this approach is beneficial to families? So we did call it, very cleverly I'm sure, the Timing It Right Stroke Family Support Program. It's not the caregiver support program because it's for everybody in the family. If the patient wants to be part of it, if anybody, the children, anybody wants to be involved, they're welcome to be involved. Because the stroke doesn't just affect the person, it affects the family. All right, so to develop the content of the intervention, what we did is we sort of said, well, okay, we have these different phases. Maybe each phase can be like a module of the intervention or the chapter of the book that goes with it. And we wanted to continue to consider the different elements of support that I mentioned earlier. And we also did a qualitative study where we interviewed 24 family caregivers from both urban and rural environments. We also interviewed 14 healthcare professionals from acute, rehab, and community care environments. And we asked everybody, we said, what supports do you need and when do you need them? What supports did you receive that were beneficial? How did you receive them? What more could we do? But we asked them to really situate it as best they could as the time post-stroke, so we could start to paint a picture of how things were or were not changing over time. That publication in 2013 goes into way more detail, so if you're welcome to look at that. We then felt at the end of that we had a fairly good idea of what supports were needed at different times, had almost like a detailed outline. We were then able to leverage existing educational resources because there's a lot of good stuff out there. We just organized it more as to when the information would be more appropriate according to the framework. We did have to develop some new material in the weekend pass aspect of inpatient rehab. Nothing is really written about that, so we developed some new materials there. And then when we had the educational resource prepared, we gave it to healthcare professionals and we said, okay, read it. What do you like? What don't you like? Let us know, be honest. And so they gave us feedback and we incorporated that feedback and then we moved on. And then anytime we took, so of course we did a lot of this work in Toronto, so anytime we took this intervention to another city, we would have somebody in that city review the content and revise to make it appropriate for their city. So that's how we developed the content of the intervention. Then we had to figure out, well, how do you now deliver an intervention that's crossing care environments? So again, we used our qualitative study, and some things that really resonated with us was, the family's, consistent request for one person to oversee their support needs. So we heard that loud and clear. They also talked about the need for follow-up after they left the hospital. One of the caregivers said, if you have a baby and you go home, the public health nurse will either call you or visit you to see how you're managing at home. Why don't we have something like that for family members who are taking somebody home post-stroke? So that was, these ideas resonated with us. We then looked at the literature, and Joan Grant, nurse researcher in the U.S., has done a lot of work around the benefits of telephone support. And of course, if you're a family member providing care to somebody at home, you probably don't want to have to go somewhere special to learn something, because now you've got to leave this person at home by themselves, or you've got to make arrangements, so maybe telephone is the way to go. Vanden Heuvel used trained nurses to support families. Lincoln used what he called a family support organizer as one key person who's providing support to the families. And then because stroke occurs in an aging population, I looked at some of the aging literature. And the PRISMA model is a really nice model of integrated service delivery, which aims to coordinate the services that the aging population is receiving in the community. So it uses a case management approach, but this one individual has a pretty good idea about everything this one aging person is receiving. So it kind of helps to coordinate things that are going on. So we decided, well, we're going to do something very similar. We're going to have what we call stroke support person. And this is one key individual who begins the intervention by interacting with the family in person during acute care, and then follows them by telephone for a period of time after that. So now we have the content, we have a plan for how we can deliver this intervention, and what's next? Oh, I should tell you who the stroke support person is. So the stroke support person, in my context and in my vision of how it would be ultimately implemented into the healthcare system, I wanted a healthcare professional in this role. So because of my affiliation with the OT program, a lot of occupational therapists have taken this role on, nurses, social workers in addition, and also other individuals. I think the other one is a physiotherapist as well, who took more of a general hat. So they didn't take their physio hat into the room, they took a more general hat, education. They had to have some knowledge or expertise in stroke management and care options, so they had to know stroke. The key things that they did, so every time they interacted with the families, they tried to cover all of these different domains, or all these different areas. So they tried to provide emotional support, so really starting with a very simple question. And actually I teach this to the OT students. I said, if you can ask the families one question, just ask them how they're doing. Ask them. So you'll get a lot of information in that way. So we start every session by asking them how they're doing. We then go to our intervention guide and we say, other caregivers or other family members in your situation have found these topics to be valuable at this time. Would you like to discuss any of these topics? And then we kind of tailor the intervention at that point in time, but we try to give them some insight that these are other caregivers have told us that these are valuable. So it may help them to say, okay, maybe I should hear about some of these things that I'm not quite sure about at this point in time. We also tried to provide tangible assistance and guidance. We recognized that this intervention was going to be time limited and that we really wanted to give families some skills at the end of the intervention. So we had this idea of adopting the principles of self-management to help families manage their own support needs. So it's not the chronic disease self-management model we're more familiar with, but it's this idea of families trying to identify their needs, problem solve to identify possible solutions to their needs, and then acting to see if they can have their needs met. So it's this idea, again, trying to give them some skills so at the end of the program they'll be more independent in able to find the supports they need. We also helped navigate families to appropriate resources. So our intervention didn't cover everything, obviously. There's a lot of great programs and resources in the community, and what we tried to do is, if a family said to us, you know, our biggest problem is communication. My family member has, you know, significant aphasia, and we'd say, okay, well, who's your speech language pathologist? Well, we don't have one. Okay, well, let's think about where we can find one. So directing them to appropriate resources. So we weren't trying to cover everything, but we were trying to help families get to the supports that they needed most. And then we would try to finish our conversations with really providing them with some feedback. You know, it sounds like things are going well, or, you know, I'm happy to speak with you more if you'd like to discuss more things, but really trying to give some of that feedback. So the result is what we call the Time-Minute Right Stroke Family Support Program, and the idea again is giving stroke families the support they need and when they need it. All right, so then we said, okay, we've got a framework, we've got a program, does it even work? Can we deliver it? What can we do? So I thought we better start with a pilot study. So we decided that we would do a pilot randomized control trial. We wanted to see how the intervention rolled out. We wanted to try to deliver it to see, you know, how much time was taken, what was easy about delivering it, what was hard, you know, how did this work? And it also would give us a chance to collect some of our pilot quantitative and qualitative data. So our pilot sites were Calgary, Toronto, and Pembroke. So I've got colleagues everywhere, and it's nice to have Pembroke because, again, that's a smaller community. So it helps to make sure our program isn't just a big city program. So our goal was to recruit 30 family caregivers, and just to summarize, you know, all of these criteria, essentially what we were looking for, we thought our intervention was going to be most beneficial to people who are novices to providing care to somebody post-stroke. So essentially we looked for people who had either a first stroke, or maybe the first stroke was mild and this was sort of a more debilitating stroke. So anyway, people who really knew very little about stroke, and because they haven't had to provide care previously. And they had to be going home, because this intervention really is about the transition home, not the transition to long-term care, not the transition to end-of-life care. Like, it really was transitioning home. So it was very focused that way. I don't need to go through this too much, but essentially we gave them quantitative surveys that they completed when they were recruited, and then we did follow up again, the same battery of surveys, 1, 3, 6 months post-stroke. We looked at the assistance the caregivers were providing, social support available to them, depression, psychological well-being, the impact that caregiving had on their everyday life, and their knowledge of stroke. We then also completed a qualitative interview with anybody who was willing at the 6-month time point, because we thought the qualitative interview would give us valuable information as to how the intervention worked or didn't work and that kind of thing. We also had our stroke support people keep journals. So they recorded the time that they spent with each caregiver and the topics discussed or resources provided. So we're trying to map out, you know, how well does what we think the intervention should look like actually look when you try to deliver the intervention. And I've got somebody in Halifax who's leading sort of this piece of the analysis. I'm going to give you a little bit of results there, but not too much. All right, so when we did the trial, we had 3 intervention arms, essentially. We had standard care, because we should always compare. If we're developing something new, is it any better than standard care? So we had to start there. And in this situation, everybody received a copy of the Heart and Stroke Foundation's educational resource, Let's Talk About Stroke. So it's just an education, information about stroke. So everybody in the study received that. Some caregivers received what we called the self-directed arm of the intervention, and this is where they met once with the stroke support person who provided them with an orientation to how to use the educational resource to help themselves self-direct themselves through the intervention. So it's sort of a less expensive sort of one-shot deal. We wanted to see whether or not that would be sufficient to help families. And then we had what we call the stroke support person delivered intervention, where we tried to meet with the families in person during their acute hospital stay, and then essentially monthly by telephone as a bit of more of an outreach. And again, like as I indicated earlier, that we did tailor the content of the intervention very specifically to what their experiences and their needs were, what they were telling us they needed help with. We didn't try to give them stuff that was not relevant to them. So we ended up with 31 caregivers in the study. Very standard characteristics, and they're very similar across our 3 groups. They typically were women in their mid-50s, caring for a spouse that they lived with. Interesting, the percentage that had previous caregiving experience. So this may have been caring for another person for another reason, or maybe the same person for another reason. Many of them were still working for pay, so they're juggling not only the caregiving role but also paid employment. And also got some information on their education and their income. So we didn't have any significant effects of the intervention. Of course, with 30, that wasn't sort of the plan, but we did do some of our preliminary analyses. But what we did learn from our stroke support person journal is that we had each person received about 5 sessions with the stroke support person for a total of 2 hours. So it's not a lot of time, really. So it's sort of, we were trying to figure out, what is this going to cost? Like, what does it look like? And again, we really left it up to the families. You know, they dictated how much time they spent with the stroke support person. So when I say there was a median of 5 sessions, I know, for example, that there was one caregiver that I think had 12 sessions. So it really varied based on what they needed and the interaction that they wanted.
The time was over 1 hour, 53 minutes was over the 5.
Yes,
Yeah.
exactly. So I think what happened is the first session was about 30 minutes, maybe plus or minus, you know, up to maybe, some of them were up towards an hour. Like this is, like, again, the median. So there were people who spent quite a bit more time. And then the other ones, you know, were 20 minutes typically. There were some who really didn't need much help. We were just checking in with them 5 minutes. So it really did vary. We'd say, how are you doing? You know, we're all great. You know, here are some things. Would you like to talk about this? No, we're all good. Like, it was just that kind of interaction. So there were some. I'll get to the qualitative results in a minute. Anyway, I won't tip you to it. Anyway. Yeah.
May I just ask, were all the family members living with? They were living with the stroke?
I think it was about 70%.
Oh, okay.
Yeah, yeah. So there would have been probably some adult daughters and adult sons in there who may not have been living with them. Yeah,
Thank
yeah.
you.
But about, like, most of them.
Okay.
Yeah. And that's typically what you'll see. So it wasn't a requirement that they live with them.
So it's both.
Yeah, yeah. All right, so we did have 19 of our family caregivers who were willing to participate in the qualitative interview at the end. And again, we asked them, you know, what supports did you need? What did you receive? What was good? What wasn't good? And what can we do better? So when they talked about their supports, we broke it down into 4 themes. And I'll go through each of these with you. So the first theme we called hunger. And I'm not sure if it was because we were doing these analyses over lunch one day and we met about them. I'm not sure how we got onto this. But what we were hearing is caregivers talking about factors that were influencing their need for support or their hunger for support. And stroke severity was fairly clear. Those who had a more severe stroke, those family members needed more supports. But also, if they had sort of pre-existing knowledge of stroke or of providing care or of navigating the healthcare system, you know, they didn't need as much support. So these were some of the driving factors. Whereas if they had very limited experience previously, they needed more support. So these were the things that we felt were really driving their support needs. And next, we'll talk about the support buffet. So the family caregivers, they talked a lot about the different supports that were available to them. And so we decided it was like a buffet, because they could kind of choose to some extent what supports they were going to use. So thankfully, they did talk about our stroke support person. Even people who were randomized to the standard care arm talked about the need for somebody like our stroke support person. So that made us feel kind of good. They talked about our educational book as being a resource. Some said they read it cover to cover. Some completely forgot about it, right? So there's definitely something going on here. They talked about healthcare professionals as being a value or a good source of support to them. And they also talked about the value of family members, friends, and peers. In my 2013 paper, there's some neat stuff on peers. It's a good group. So then we felt that there was something else going on here. So it wasn't that hunger specifically drove the selections from the buffet. There's something else happening. And we found that, you know, caregivers who had a high level of mastery, and these are people who have a pretty good sense of control over things. They're the ones, when I'm talking to healthcare professionals, I say they're the ones that are going to come in to see you and they're going to have a list of questions. You know, they've figured it out. They know what they need to ask. So those ones, you know, they're going to be maybe a little bit more selective about what they took from the buffet. If they're in good mental health, they were sort of doing a bit better as well. And again, this idea of the ability to ask questions. So those caregivers were going to choose, you know, certain things from the buffet, whereas those who had less mastery may want all of it, or they may just be desperate for support. So there's some differences going on there. And then at the end of it all, caregivers, we felt that caregivers were more satisfied with whatever supports they received if two things essentially happened. One of which was if they had a reasonably good idea or an understanding of what to expect next. So they had an idea what was going on and what they could expect. And the other, so it's more like the educational piece of it. The other aspect was that they felt prepared for their caregiving role. That's the hardest one. And very few of them do, but if they were getting enough supports, if they could get the supports they wanted, then they would feel prepared and things would be better. Now, the next slide I'm going to show you is very preliminary, but as we were reviewing the data, we felt that we could kind of categorize our caregivers as to whether or not they had high hunger and they really needed support versus those who had a low hunger. And we kind of rolled this in with the appetite as well. So the low hunger people with high mastery, you know, they were a little bit different. So what we felt, and again, this is preliminary because we don't have a big enough numbers, but this was our interpretation of what we were reading, was that if they had a high level of hunger, they really wanted the stroke support person arm of the intervention, whether they received it or they wished they had received it. If they received standard care, this was not good. But if they had a low level of hunger, they really only needed the self-directed arm of the intervention. You know, they've got an educational resource, and also standard care with an educational resource was sufficient. So it seemed to us that hunger was really driving what supports families needed. And I think if we could think about it from a healthcare system perspective, if we can figure out this hunger thing a bit better, we can start to tailor the intervention or target specific caregivers who really need the help, and so to leave the other ones maybe alone a little bit. So it helps when we're thinking about scarce resources, right? So in summary from the pilot, the stroke support person spent about 2 hours over 5 sessions. Those with the high hunger benefited from the stroke support person arm of the intervention. Low hunger, self-directed or standard care, and then appetite seems to moderate something here. So hunger and appetite. It's got some work to do to figure this out a bit better. All right, so that led us on to the full trial of the intervention. So this now is a multi-province randomized controlled trial. You know, as a junior faculty member, they say that if you can't run a trial, you shouldn't get tenure. And I don't know if I even want to ever do this again. This is one of the hardest things I've done. But anyway, so the idea here is that if people receive the intervention, does that make them feel more supported? Does it give them more knowledge about stroke? Does it make them feel better from a mental health perspective? So that was what we were trying to learn. We had specific hypotheses. My numbers are a little light. And essentially the idea was that if you move from standard care up to the self-directed arm and up to the full intervention arm, there should be benefits, you know, as you go up. So our goal here was to recruit 300 family caregivers. We're again looking for the same people we looked for in the pilot, essentially novices to the caregiving post-stroke. So what we did is we recruited them during acute care. So once somebody had a stroke and it was confirmed, we would show up and try and recruit them into the study. We wanted to start early. We'd collect some baseline data. We'd randomize the person to one of the intervention arms, begin the intervention, and then complete surveys 3, 6, and 12 months post-stroke. And then we also did qualitative interviews with a subset of our participants at 12 months. So again, the value of the qualitative, I tell you. It's how we figure things out, I think, really. All right, the same series of measurement instruments, essentially, in the well, it didn't show up as a lighter color there, but on the lighter color on mine. But the qualitative interviews and the economic analyses, we've collected that data. We just have not yet started to analyze it. So I've just sort of put it on the side because we'll be looking at that in the next couple of months, actually. We just did a series of descriptive analyses. We summarized again what the stroke support person journals were telling us. And we're using more of an advanced form of statistical analyses called hierarchical linear modeling. It just sort of gives us a little bit more power to be able to determine differences between the groups. We had 11 cities across the country, right from PEI over to Calgary, a lot of sites in Ontario, because of course we have the Ontario Stroke System and they're quite motivated to develop and test programs that support families. This is a complicated diagram, but essentially we were able to get 310 family caregivers. We randomized them into 100 into standard care, 106 into self-directed, and 104 into the stroke support person intervention. We were able to keep, a lot of people in, almost 60, right through to the 1-year follow-up. We had people withdraw at different points for different reasons. But essentially the groups remained fairly comparable over time. So we did a pretty good job. It was a lot of work to keep people in the study, but it was. And actually, if you look at how many people, we had to screen over 4,000 people to get our 300. So what was happening is that a lot of people didn't meet our criteria. So they either weren't going home, they were palliative, or they had had a previous stroke before that was significant. So we really lost a lot of people. We had, language ability, because everybody had to be able to do all of this in English. So we lost, people from that perspective as well. The missed, 575 situations where we could not. We hung around the acute care hospital. The family member was never there when we were there. So we just could not interact with them in any way, shape, or form to try and get them in the study. So that's what we did. And then we look at some of their characteristics. And then what I've highlighted here in the red are some nuances that resulted in the groups not being equivalent, which, you assume when you randomize people in a trial that all of the groups would be the same. But what we see for some reason in the self-directed arm of the intervention, there were fewer females than in the other two. So these are things we have to now start to figure out how to take into consideration in our analyses, and we haven't quite figured it out yet. A smaller percentage had provided care previously. If we go down to education, it seems that the standard care group was less educated than the other groups. If you look at the CNS, which is stroke severity, it suggests higher scores, suggests less severe stroke. So it suggests that the people who are on our stroke support person arm of the intervention had milder strokes than the other two groups. So we've got a bit of messy data right now, and we've got to sort of figure out how to deal with this and how this might influence our findings. But other than that, the caregivers and the patients were pretty standard. We've got 85 to 90% who have had ischemic stroke, and that's what you would expect if you just went into a stroke hospital. That's typically what you see. Discharged to rehab, actually a higher percentage than normal, because usually it's only about 30% that get inpatient rehab, and otherwise people are going home. So higher percentage going home.
So are you saying an average age for stroke is around 69?
Yeah.
Really?
Yeah.
I would have thought it was.
I know, it's interesting, isn't it? There's so, and actually it's funny because I gave a presentation of our baseline data at the Canadian Stroke Congress this past fall, and I was in a session that another person came up and presented, also some stroke data, and our average age was the same.
But maybe that's because these are people discharged to home
Yeah.
as opposed to going into some kind of assisted care.
Exactly,
Right.
exactly. Yeah, and I have my numbers later on, but I can't remember exactly how many were going, but yeah, no, that's true. And also the issue if somebody has a stroke from assisted care, they don't always get to the hospital, right? Sometimes they just keep them in the facility.
Mini stroke in terms of, or,
Yeah.
wow.
Yeah, I'm not exactly
Or it
sure.
depends on the facility, right?
Yeah, yeah, and what resources they have
Like
available to
Baycrest,
them.
You're not
Oh, exactly.
going that far.
Yeah,
Yeah.
yeah, exactly. All right, so these are some, I'm highlighting these because these are some things that we still need to figure out. So we essentially, we got all of our data in completed probably November. So it's really been December and January that we've been starting to analyze these data. So we're really at the early stages. We're trying to grapple with it. I was doing work yesterday, and all of a sudden I realized, oh, I've got one of my variables wrong, and I had to redo everything. I was able to fix it quickly and redo everything, but anyway, so this is still a work in progress. So I'm leaving you with a bit of a cliffhanger, actually. Susan's come in and said, present the results. And I'm like, I will get you so far, but I don't have all the good stuff yet. So again, when we look at how the intervention was delivered, just the self-directed arm, again, they had one meeting. That was the goal, was for them to have one meeting. It was about 32 minutes long. And then, interestingly enough, 42 of them were in person, and 50 of them had to happen over the phone. So again, this has to do with how quickly people are discharged. So if we can't get our stroke support person there right as fast as we can, they're gone home. So then we had to do it. So what the plan was to have that first session in the acute care hospital, didn't work all the time, only about half the time. So that was an interesting learning lesson for us. And then in the full intervention, remember from the pilot it was 5 sessions, now it's only 3.5. So it's gone down a little bit. So I'm not sure if it was milder stroke or something, I'm not sure what's going on. And the amount of time spent is also less, which is interesting. And then we have different stroke support people. We have a different person at every city. And again, you can see that in person, about 47 were done in person, and then 44 by the phone. And then you can also see that in both groups, 13 people had no interaction with the stroke support person. So that's a bit problematic for us, especially when you're comparing. These 13 people are included in my analyses, although they had 0 intervention. So. So that's sort of how it rolled out in the context of the full trial. And then here's the results. And I'll just highlight nothing. We have no significant findings at this point in time. So what this has tested is basically a time by group interaction. So the idea is when we compare the stroke support person versus the self-directed arm, or the stroke support person versus standard care, or the self-directed arm versus standard care, over time. The expectation is that somebody who receives the intervention, their depression might go down faster than somebody who doesn't receive the intervention, so you're looking for an interaction between these 2 lines over time. So that's what the analyses are trying to do. They're sophisticated in some ways, but in some ways they're kind of hard to wrap your head around. And as of now, we have no significant effects. So we've done all this work. But next steps. We do know from the pilot that we've got to do the qualitative data analysis, and I think that's going to help us understand more as well. But we do know from the pilot that there are certain caregivers who need the intervention, want the intervention, engage in the intervention, and now we have to figure out how to pull them out and compare them to maybe people who don't need the intervention to see whether or not we can really identify those who benefit from it. So we still have more work to do, and that would be in our subgroup analyses. We also have collected a lot of economic data to see, the cost of things. Are we able to, if a family caregiver is managing better at home, does that mean the patient's, having less emergency room visits? Like, we have this kind of data as well, and I'm meeting with somebody in 2 weeks to start to plan the analyses for that part of the data. And then last and not least was that when I wrote this grant, I was a junior faculty member, and I knew that granting agencies were only going to give me so much money as a junior person, and everybody said, well, you're going to have a patient piece to this and a caregiver piece, and my budget would have been too big, so I said, we'll leave the patient piece for now. About 1.5 years ago, I wrote a grant to the Ontario Stroke Network to allow us to do a patient sub-study. So now we'll be able to look at the intervention and see whether or not, if a caregiver who receives more support, if that translates into any benefits for the patient. So we'll be able to do that. And I actually have a postdoctoral fellow who's just started and who's going to be specifically looking at this data. All right, so I've come to the end. I have quite a great research team of investigators and collaborators. So I've been trying all through my program of research to try and work very closely with the people who ultimately could use the work that I've done. And so they help to make sure, so we had the self-directed arm of the intervention because people said, well, what is one shot good enough? And that was, people who were thinking about resources and resource allocation. So we had that in coming from our collaborators. They also said, well, you know, Jill, the likelihood of us having the resources to send somebody to their home to see how they're doing is very low. So let's, you know, the telephone idea is great. We really like that. So continue along that telephone idea. So that's what our collaborators have been great at doing, is really sort of providing that real practical world. You know, this won't fly ever, or this would be a good idea. So I like the way you're going in this direction. So we've been lucky to work with these people. I have an amazing project coordinator, Anna Serwanka, who is in Peru right now. She's probably online. She said she's going to join online. You know, the ultimate work from home when you're in Peru. But anyway, she's great. We've been working with this data together all hours. So that's my team. I've been fortunate to have caregivers and healthcare professionals willing to participate in the studies all the way along and provide insight. I've also had money, which is key. The large project was funded by the Heart and Stroke Foundation. The smaller projects were funded by CIHR. And I'll just leave with this. Those of you who may or may not know that the For Better or Worse comic strips, her father had a stroke, so she did a whole series of comic strips on stroke. So this one I liked. I can read it to you. Now that someone's with Jim, I might be able to go out for a while. I could visit a friend or walk to the corner store or sit in the park and watch the people go by. Iris, we're fine on our own here. Why don't you go out and get a little fresh air? Thanks, Christine. I think I will. There's nothing like a coffee break when you're working 24/7. So I like this. This sort of brings it back as to why I do the work that I do, is that it's for these individuals, you know, trying to make things a little bit better for them. So that is it. So thank you. So does anybody have any other questions? I know we've been asking questions along the way.
I have two from
Okay.
online.
Yep.
The first one, someone asked me about the slides,
Okay.
and I didn't know whether you wanted to distribute them at this point in time or just keep them within the webcast.
We'll
but,
keep them in the webcast because just because that we're writing up the pilot paper and these results, the quantitative results are preliminary, so I really don't want people saying that these are her findings because I'm really at the early stages. I've got to go and sit down with a statistician and think this through a little bit more. So, but on the website, it's perfect.
Okay.
Yep.
And the other question is from Marina. I wonder if you see a place for emerging technologies like Skype, FaceTime in the intervention. You also mentioned that you came across some interesting peer support findings. Do you see a role for peer support in the intervention?
Should I tell you who Marina is? My PhD student who's looking at the use of online technology and peer support. Is her specific interest. So yes, Marina, of course, absolutely. But the peer support piece for me was the most interesting aspect, was that peers were most beneficial at specific times, and it was as they were preparing to take somebody home, the role of peers became most important, and then all of that time in the home environment, because caregiving peers who have been through it provide the best practical advice on how to do the caregiving role. They also were one of the best go-to people for any emotional concerns, because the caregivers are not going to complain to other family members. They're not going to complain to the stroke survivor. They're not really interacting with the healthcare professionals at this point in time. So if they're upset and they just need somebody to talk to, peers came in as an important role, important piece. Of course, the online, support is key. It's big. Like, what we've done so far, the television is low-tech support. Maybe Elsa Marziali at Baycrest has been using online web-based support groups where people can, come from different areas, see each other, and interact with each other, as opposed to having to be in the same room together. So, yeah, definitely, Marina, go. Keep going. She's running into some snags with her recruitment right now. So she's, if anybody has caregivers and they want to support Marina's study, let me know. So she's specifically, what are you looking at, Marina? You'd have to tell us. Is it adult children at this point? I can't remember now. But she's looking at people's use of in-person versus online supports. and trying to compare the two. What are the nuances between the two? How do they interact with peers? Does it make a difference if peers are more similar or more different from them? So she's got a lot of good work in progress, but she's looking for caregivers to do a survey and a qualitative interview as well.
Anyone with any other questions?
So I have my email address there. I'm always, if you have any questions at any point, for sure, shoot me an email. I have no problem. Yep.
Do you have, when you have these interviews in person,
Yep.
do you include the stroke victim?
Typically, no. What we found is that if you try to speak with both of them at once, I didn't feel that the caregivers were always so forthcoming on their experiences. So what we tried to do is pull them off to the side and say, how are you doing? So really try to hear from them what was going on. In our sub-study that we did with patients, we're doing both surveys and qualitative interviews. So now we pulled the patient aside and we've said, how are you doing? Like, what's returning to community living being like for you? And what things worked and what things didn't work. So we tend to pull them apart just because of the dynamic. We want to hear each individual's perspectives. Yeah.
Did I hear you say that you had, for the self-directed,
Yeah.
you had a guide
Yeah.
that they would read through? Is that available to the public?
What are we doing with it? So it's finished the research phase. You can email me if you'd like, and you can have a copy of it.
Oh.
So we've got it in PDF format. So basically, anybody so what we did is it's like a 200-page guide, and we have one for each of those 11 cities that's specific to that city. So yeah, because it has all the specific resources. We have a whole resource section at the back. It's probably a bit outdated now, but the idea was to have something that they could look at in addition to interacting with the stroke support person. So the person in the self-directed arm as well as the stroke support person arm, they both received that detailed guide.
Because it sounds like a good resource in itself.
Yeah, I think it is. I think, that's what most people would say, if they needed something, they could easily look it up. But yeah, it's I'll tell you, because we did in the context of research, it's not at a great reading level. It's probably a little high. But anyway, so it's available, yeah, for sure. Yeah.
Do you know if the Heart and Stroke Foundation has peer support groups for care, for?
You know who it is?
spouses,
Is it the March of Dimes or is it the Stroke Recovery Network? One of those, or both probably, have a little bit more. And I think so that's probably, I think they're the driving forces behind the peer support piece of it. It's those two groups. March of Dimes for sure, and I'm pretty sure Stroke Recovery Network. One of the groups in Ottawa had a neat thing where they would have a peer-to-peer interaction. So this was stroke survivor only. I don't know if I'm not sure how developed their family caregiver piece of it was, but they would have a stroke survivor come to the acute care hospital and interact with somebody who's just been hospitalized for stroke and say, hi, my name's Joe. I went through this 3 years ago. When you're all, when you want to talk to somebody, here's my card, give me a call. So they're trying to establish that. I know in Pembroke at one point in time, they were trying to do the same thing in the community for caregivers. It's very, very hard. So I think Marina's work with the online piece, might help. There's a website, Patients Like Us. If you haven't seen that, it's a great site. And it allows people to go in and say, these are my characteristics, and helps you link up with other people that are similar to you. Yeah, I think it's called Patients Like Us. Yeah, so there are a lot of resources out there, and again, it's interesting. You're in the field, and so it's like, how do families ever figure out what's available to them without somebody helping them?
Well, I have a woman who's just started, and her husband has started bringing her and brings her every day now.
Yeah.
She doesn't know what's happening.
Yeah.
She has no idea. She's saying, they don't tell me anything, we're out and here I am.
Yeah.
And is this gonna get better?
Yeah.
Yeah. And he's scrambling, and that Patients Like Us sounds like a great thing.
Yeah, so it's
for others
online.
to look
Yeah.
at.
Yeah, and then again, like the March of Dimes for sure. I mean, the Stroke Recovery Network. If they want, so some people really do want to sit in a room and interact with somebody, and some people are really just happy to do this online. So there's different types of people. So it's nice to know that there are both types of supports available.
Like ours is a social group.
Yeah.
And some have been coming for 13 years. Some are
Yeah.
really new.
Yeah.
But when new people come in, they can sort of talk to each other.
Yeah.
But they're all coming in at different times.
Yeah.
From 48 to 85.
Yeah.
So
Yeah.
And
Yeah.
we don't know when
Yeah.
they've come. And they've probably been told to come at rehab. But
Yeah.
some of them wait 2 years or 4 years, or some of them come immediately.
Yeah.
You know?
There's also a young, was at a young stroke survivors support group in Peel, somewhere in Mississauga, I think. And I thought that was interesting because these people are very young. And now it's really hard for somebody who's had a stroke in their 20s or 30s to interact with somebody who is 60 or 70.
We have 48 who's
Yeah.
in long-term care.
Yeah.
And we don't usually have people come in long-term care to our adult day program.
Yeah.
But of course he would want to get out of there.
Yeah.
It's not really.
Yeah.
Well, there may be a floor for younger people. I have a friend who's in his 40s who is cerebral developmental issues, and he's in
One would
long-term
hope,
care.
yeah.
So
Yeah.
not from stroke, but from
Yeah.
birth,
Yeah.
and disability.
Mhm.
And there are younger people floors
Yeah.
or areas in.
But it would depend on numbers. Right?
Well, yes,
Yeah.
exactly.
Yeah.
Exactly.
And on the facilities, sort of paying attention too, right? Like whether or not they're sort of recognizing that people might want to be grouped differently. Because I know that one of my research areas, we had people who have survived a critical health event and they needed rehab, but there wasn't a clear rehab path, and they ended up in geriatric rehab. And of course, that's not what they wanted. So you really do have to. And this is trauma rehab, but they didn't have something that would be appropriate for this person at this age. So you have to. I mean, the organizations have to be aware as well.
Have the cutbacks in video impacted these issues?
That's a great
Financial
question.
cutbacks?
I'm assuming yes. Well, it's interesting because when I think about, I've done research over the years in my PhD research. I specifically looked at receipt of home care services with this idea that if people were receiving more home care services, it would make the caregivers feel a bit better. But I think that the level of services are so low to begin with that like the CCA services is so low and so hard to get that I'm not sure. I mean, it's probably worse with less physio and less OT, but
Well, my understanding, they used to even pay to come into retirement homes and nursing homes, and apparently they've cut that out.
yeah,
Which I find with very little fanfare. I
Yeah,
mean,
yeah.
there was
Yeah.
very little.
Yeah.
I was quite surprised that there wasn't more opposition
yeah,
from the general public, because with the baby boomers all getting older,
Mhm.
that's who that's going to impact, and
Okay.
not everybody's going to be able to afford private physio.
yeah.
So
Yeah, no, it's a huge problem for sure. I have some of my colleagues that are specifically do work in that area, so they do listing of services and yeah. But I think again, from the family's perspective, they need more in the support in the home, and they need to have more say into what's coming in. Because what I've learned from most of my research is that families say, well, they don't ask me, they ask him. Or they ask her what service she would like, and based on that conversation, they allocate services. Whereas the family caregiver said, well, what? To be honest, he says he can, easily do this, but really he can't, and I have to do all of this. So if you could provide a little more help with that, that would be great. And that doesn't quite happen at this point. So taking more, I call it family-centered care. Whereas, client-centered care, patient-centered care is great, but the family piece isn't really clear and really upfront in those definitions. So I think this idea of family-centered care and having people look at the whole family unit when they're allocating services would be a little bit more helpful. All right. So thank you all for coming
That
on
was
this
awesome.
cold day. Thank you.
It is the weather, I think, that's